Hello, greetings everyone. This is Dr. Srinivas Kishore, Director of ENT and Sleep Apnea Services. Um, Whenever we talk about drug-induced sleep endoscopy, uh, this seems to be like the holy grail of evaluation. Because right from its inception time, such as right in the 90s, it didn't really pick up to the present level it is today. It's in the beginning of the last decade that a lot of strides were made in the way we do in drug-induced sleep endoscopy, the way we interpret drug-induced sleep endoscopy, and the way we characterized drug-induced sleep endoscopy. So, is drug-induced sleep endoscopy really useful? Or, as the name suggests, drug induced, are we looking at something that is probably not that true to its name and it may be all misleading? So, in the next 15 minutes, let's just cut the clutter and see what's happening in terms of drug induced sleep endoscopy. Is it useful? Is it misleading? So, as you all know, obstructive sleep apnea is a multifactorial condition and is associated with potential physical and behavioral sequelae if left untreated. And today, CPAP is the first line of treatment. But we all know that adherence is a problem. Now, if you failed CPAP therapy for obstructive sleep apnea, that means if you fail the gold standard therapy for obstructive sleep apnea because of various issues, now that's a different talk for a different time. What are our other options? Your other options are oral appliance therapy, positional therapy, and surgery. Now, it's not specifically in that order, but it's a trial and error method. Well, there are certain phenotypes and endotypes that respond well to each one of these treatments. And of course, we will discuss each one of them as we go about with our presentation. So, at this point in our talk, let's focus on what our other options are. So we know that the other options are oral appliance, positional therapy, surgery. Now, we all know that obstructive sleep apnea is not some simple problem. It is actually a conglomeration of various kind of mechanisms that are sort of uh, manifesting in this form of condition called obstructive sleep apnea. Like, for example, there are so many comorbidities as a part of sleep apnea. Then there are a lot of anthropometric parameters. There are lot of pathophysiological parameters. So all of this also have to be taken into consideration when you are sort of trying to give some kind of a treatment plan to a patient who has failed CPAP. Now, it's not about failing CPAP immediately. It is literature's filled with data that basically says that if somebody is non-adherent to CPAP in the first 1 week of giving the therapy to the individual, it is highly unlikely that they will become magically adherent. So that 1 week to 3 weeks time is very important. So it's up to us also to sort of try and see what are the factors that can make the particular patient sitting in front of you non-compliant to the treatment that you're offering. That is CPAP. So, in order also to identify the patients who would be non-adherent to therapy, also to identify people who why they are non-adherent, and also to try and give other non-PAP therapies, you need to come out with certain ideas as to how are you going to decide on what kind of treatment you're going to offer to the patient who's sitting in front of you. So it's like opening a door. Which door are you going to open? And unfortunately, you can't ask Dr. Strange for all the answers because he has enough problems to count. So, drug-induced sleep endoscopy sort of completely fits into that vacuum that is being created where, in terms of evaluation, you're not sure how to give the different treatment options to your patient. So, drug-induced sleep endoscopy provides a unique viewing mode to directly examine continuous dynamic changes that are happening in the airway lumen during sleep. So, what is drug-induced sleep endoscopy? And all these particular words that have been highlighted in yellow are important. Drug-induced sleep endoscopy basically involves an endoscopic upper airway evaluation or examination because OSA is happening in the upper airway. It is an examination that is done during unconscious sedation, identifying structures that contribute to airway collapse. So, DISE technique is based on research indicating that upper airway physiology at the transition from unconscious conscious sedation to unconscious sedation has similarities to physiology during natural sleep. So, with that background, in the past 20 years, research on targeted therapies for DISE subtypes has increased year on year, and series of position papers have been proposed. And one of the most famous one is the European position paper on drug-induced sleep endoscopy. I think you guys should go and check it out by a lot of leaders in the field. So through DISE, phenotype of the upper airway obstruction has further refined according to various sites and collapse configuration, going beyond conventional definitions such as pharyngeal cavity narrowing or tongue hypertrophy. We've moved away from those kind of terminologies to sort of trying to understand and describe airway in a more dynamic fashion. So, what are the classical indications? The classical indications, as you know, are patients with OSA and for patients who need treatment offerings beyond non-PAP, patients with previous surgical failure and an agreement for oral appliance or a surgical intervention, children with residual OSA after adenotonsillectomy, and patients with CPAP failure or intolerance needing to identify the reasons for failure. In addition to classical indications, there are a lot of interesting advances that have happened, and what we now call them as airway characterization with DISE and also interventional DISE, wherein we are trying to put in the various sort of treatment modalities while we do DISE and see how the airway is behaving, just to see how we can improve on the present therapy or the reasons for failure for the therapy that has been given, or in addition to the therapy that was given, some other adjuvants can be given. So a lot of work has also gone into using DISE while doing applying positive airway pressure, and we are trying to understand the behavior of the upper airway. Now, The idea is while we do DISE, you want the upper airway, which is like this in a patient with sleep apnea, to look like this. That means whatever therapy you're offered, if your airway is moved from this to this, means your pharyngeal airway is opened up. Means a patient who is having severe sleep apnea because of high peak rate is moving away to a state where there is low peak rate because of the treatment that you're planning to offer that you've already offered. Now, peak rate or pressure critical is basically that pressure at which the upper airway ceases to open, or the inability of the upper airway to keep itself open is the peak rate. So what happens in sleep apneic patients? Their pressure is high. That means it's at 0 or +1 or +1 +2 or -1 -2 in that range. For somebody who doesn't have sleep apnea, peak rate is at -4, -5, -6, etc. So the aim of your treatment is to move away from high rate to high peak rate to low peak rate. And this is exactly something that you can actually do while so if you can see here, we're giving very high pressures and the airway is wide open. So if you
clear kada? Yes, sir.
if you look at this here, it's very wide open. But as you reduce the pressures, as you can see here,
Sorry.
The airway is very open. Now, if you reduce the pressure to say 6, see what happens to the airway. Completely
10,
collapses.
10 చేద్దాం
So you
second.
know, based on if it is
15,
requiring
10.
high pressure to open, that means the peak rate is high. It
15,
is requiring very
15,
less
15.
pressure to open, that means its inherent capacity of the upper airway is not there. Now, what you can also do is to put in what is called as the SAM-MAS device, which is a, while you perform DISE, you can actually measure how much mandibular advancement that you can do, and you can see how the airway is actually opening up. And instead of just doing a trial and error method or uh, doing a titration overnight with a CPAP machine, this is far better. So, and this is actually given very good results. Thanks to Patricia Fernandez for such a fantastic device, and which is helping so many of our patients with mandibular advancing devices. So, this is the same paper that's basically from PGI Chandigarh, wherein drug-induced sleep endoscopy with PAP uh, has actually thrown a lot of light into how the airway is behaving. So, in this conclusion of this particular paper, which got published in 2023, they found that the palate and the lateral pharynx were more affected by PAP than hypopharynx. This we always knew somehow, but this is now very clear by the study. And most of the time, the mean 95th PAP titration pressure, that means the pressure at which the pressure that is required 95 or it's there 95% of the time to keep the airway open was lower than the mean optimal pressure needed to alleviate the collapse. That means your PAP doesn't need too much of a pressure to open the airway. You just need a little bit of pressure to open the airway. So again, so on and so forth, lots of other papers uh, from Professor Plaza and his team in Madrid, wherein a use PAP with DISE, a useful procedure to evaluate the upper airway. Again, the similar kind of paper association with soft tissue measures for CT and upper airway collapsibility on drug-induced sleep endoscopy, and they found that after controlling for clinical factors and skeletal volume, greater tongue volume was associated with more severe collapsibility during DISE. So these results are in concert with previous work suggesting that greater tongue volume in a smaller skeletal framework contribute to severity in airway collapsibility, which is one of the key drivers of OSA pathogenesis. Now, this is something that I would encourage all of you to read. A fantastic paper authored by Ottavio Piccin, Nico Di Viri, and Olivier van der Wacken and Claudio Vicini, wherein I had the opportunity to write a chapter on patient preparation and positioning. This is something which we have published ourselves, understanding the correlation of polysomnography findings with drug-induced sleep endoscopy and how polysomnography parameters, when we see it in terms of apnea, hypopnea, can be actually seen in drug-induced sleep endoscopy. And the higher the AHI, the higher the hypopharyngeal collapse, so on and so forth. Now, also, there is lots of data that got published on pharyngeal manometry and upper airway collapse during drug-induced sleep endoscopy. So, if all is good, what are all the limitations? The limitations are, number one, there's a lot of debate about whether this is natural sleep or drug-induced sleep. The second thing is about depth of sedation. How do you know how deep you're going? Number three is about the differences in the drug used, and the fourth is the inter-rater variability. Let's start from the first point. So there are no studies that have been able to identify the presence of REM sleep during DISE. Whatever drug you use, you need to understand that. And one, you need to also understand that DICE is a very labor intense kind of a study,
వాళ్ళకి
especially
శాంపుల్
when you
కావాలంట
do it
దే
for
వాంట్ us టు
kids,
పోక్ అగైన్
especially
అంట
syndromic
యు ఓకే
kids.
విత్ ఇట్
You can't do it just by
గివ్ us one
yourself. You need to have a lot of team. You need to have your anesthesia team. You need to understand that your patients are sleep apneic patients, they're syndromic patients, they may have various other comorbidities, and also you need to have resources to record the dice, so on and so forth. So it's a labor intensive. cancer process. And does doing DISE improve surgical outcome with all this, right? You put in so much effort. Does it improve outcomes, right? And this is a paper which I was a part of, wherein we did, it's a multi-center study, and we found out that actually drug-induced sleep endoscopy does not uh, affect the outcome of patients. Now, this is something that can be debatable, but that's for a different time. So this is another paper again by Mark Lumen, who actually again said that is drug-induced sleep endoscopy associated with better outcomes? And their conclusion is very similar to ours, that soft tissue surgery does not give better results after DISE compared to when DISE is not performed. The other limitation is that now for ENTs, it becomes very natural to look at the upper airway. But sleep apnea management is not an ENT alone main. There are maxillofacial surgeons, orthodontists, pulmonary medicine specialists who all are equally involved in managing these patients. And there is a lot of lacuna in coming in from those specialities. And some studies confirm that DICE-based decision making improves response rate while others don't. Now, what about natural sleep and drug-induced sleep? Till now, I spoke about the limitations, but here I will present to you certain papers that basically said that whether it is drug-induced sleep or natural sleep, the outcomes were very similar. I would encourage you to read all of these papers. This is again another paper that basically said that natural sleep endoscopy had very similar kind of patterns of collapse as in drug-induced sleep endoscopy, basically boosting the fact that drug-induced sleep endoscopy is probably giving you findings which are similar to natural sleep, and it's not creating some kind of a utopian picture. What about depth of sedation? So when you use bispectral index scoring, which is a computer generated number that is created with because it's just a number that comes in, gives you depth of anesthesia. And when you put in target controlled infusion, which basically calculates the patient's uh, pharmacokinetics to give us good results in terms of the severity of depth. So when you are putting a target control infusion, you're sure that you're not overscoring your patient. So here is it's a very nice paper, the influence of different application patterns of propofol. So when you give it as a bolus, when you give it, how you give it and what you are getting. Um, so uh, here in conclusion, they said 14 milligram per kg per hour appears to be the appropriate application rate to reach a sedation depth corresponding to N2 sleep. Here they've said S2 sleep. And a sedation rate of 18 mg per kg leads to deeper sedation corresponding to S3 sleep. So this is based on dosage. So for those of you who do not have this, you can use this protocol. Why is BIS so important? Because if you look at this patient and this patient, a lower BIS is associated with a more severe collapse, where a higher BIS is associated with a stable airway. So you need to take the BIS to a 50 to 70 range, which corresponds to N2 and N3 sleep. Now, also, what about inter-observer agreeability? Now, there's again a lot of papers, especially from Marina. She's called the queen of drug-induced sleep endoscopy. Lots of papers that basically said that there's a lot of agreement, inter-observer agreement. But you need to be very clear that there is a difference between an experienced and a non-experienced person when you do DISE, when you interpret the reports. And that is possibly one reason wherein other specialties are lacking the finesse to interpret this. Now, is there image interpretation? Is image interpretation drug-induced sleep endoscopy really available? Again, this is a paper from France by Mark Blumer, again saying that there is so Dr. Blumen doesn't seem to be very happy with DICE, but the kind of work that he's done in the earlier years, I think 2018, he's published many papers favoring DICE. So this is another paper, basically inter-rater reliability of different scoring systems of drug-induced sleep endoscopy. Again, saying that the inter-observer reliability for both classifications based on the PT-LBE classification by Vic Weir from UK and vote by Eric Kazarian in the US are fair to moderate. So whatever sort of grading you use, there is inter-rater reliability. Sorry, I'm bringing in all this data because the more data this is published data to sort of let you know that if you're performing DICE and you are going by DICE to decide on management for your patients, there is a lot of science out there that's going to support you. This is our study wherein we also did our share to see if there is inter-rater reliability. So duration of study is also important. It has been found that a minimum of 15 minutes is required to interpret DICE. If you're doing it less than 15 minutes, doing it in 5 minutes, you're not going to get good sort of study. What about differences in drugs used? Dexmedetomidine versus propofol. Initially, all of us were super fans of dexmedetomidine, but this is a level 1B laryngoscope publication basically saying that dexmed shows a lesser degree of airway collapsibility and a higher oxygen saturation levels at greater sedation depth during DICE, whereas propofol has a faster onset of action and emergence from sedation. But basically, dexmedetomidine, which is known as Presidex outside India, is basically has some kind of an airway protective effect, and that's why a lot of people use it during bronchoscopies and stuff like that. What about impacts on clinical outcome? So, surgery for obstructive sleep apnea, sleep endoscopy determines outcomes. Again, lots of papers out there that performing drug-induced sleep endoscopy and going by uh, the outcome measures which are for and against good outcomes, supporting, for example, the presence of complete circumferential collapse, as we call it CCC, at the level of the soft palate, and complete AP collapse are bad outcome measures. um, Findings like these have actually very true. Even we've seen that in our experience that if you have these and you do a surgical intervention, your results may not be that great. Now, again, drug-induced sleep endoscopy in improving outcomes in barb pharyngoplasty, and this is a prospective randomized trial. Drug-induced sleep endoscopy has improved outcomes from 60% to 83%. So if you were to do DICE and do drug-induced and barb, it has improved outcome. Again, preoperative drug-induced sleep endoscopy improves outcomes. Again, paper basically coming out of the US saying the same thing. Can drug-induced sleep endoscopy improve success rates in tongue-based surgery, not just palatal surgery? Yes, it does. That's the uh, retroglossal obstruction. This is a patient with tongue-based obstruction. This is huge lingual tonsils. What about oral appliance therapy? There are certain phenotypes that do well. So if you have an obstruction at the level of the epiglottis and at the level of the velum alone, it has been found that if you put drug-induced sleep endoscopy, the results are not that great. So in these patients, if you offered surgery and then did drug-induced sleep endoscopy, that improved outcomes. Again, drug-induced sleep endoscopy and simultaneous polysomnography to predict the effectiveness of mandibular advancing device. No matter what kind of tool you use, when you do it with DISE, it's a it actually helps. Whereas MMA is the only procedure that wherein you can actually do uh, surgical intervention even when you have complete concentric collapse. Um, this is a very nice paper again suggesting that ultrasound can predict drug-induced sleep endoscopy findings using machine learning model. This is a very small study of about 20 patients, but there is a light at the end of this tunnel. So maybe ultrasound can someday replace drug-induced sleep endoscopy. So with all these data, dear colleagues, drug-induced sleep endoscopy has undeniably become the most common and the most widely performed OSA method. DISE not only provides clinicians with valuable information about the size, pattern, and degree of obstruction, even though there is some evidence that DISE can be misleading through some publications, there is overwhelming data like the one that I just shared. There's a lot of data that I brought in for you. Did a lot of homework, basically show how drug-induced sleep endoscopy can guide non-PAP therapy based on the evidence that it can give, based on the findings that it can give, improve outcomes for your patients. Uh, Thank you very much, and thank you for your patient listening.